We are honored to welcome our next speaker, Dr. LAKSHMI Kumar. A prominent expert in anesthesia, Dr. LAKSHMI possesses fellowships in pediatric anesthesia and critical care and currently serves as the professor and head of Department of Anesthesia at Amrita Institute of Medical Sciences, Kochi. She specializes in liver transplant, pediatric and neonatal anesthesia and critical care. She has multiple publications in national and international journals. I now invite Dr. LAKSHMI Kumar for the presentation on How I Do It, Renal Transplant. Over to you, ma'am.
So good afternoon, ladies and gentlemen. So I hope the postgraduates are here. Can we have a show of hands with postgraduates? Just a sprinkling. So be ready for a barrage of questions, okay? Because it's a topic which I've spoken about so much that I'm getting bored. So how do I do a renal transplant? This is just my perspectives, and I would definitely like you to question or whatever practices I'm going to talk about. So what you're seeing on the screen is a Cockcroft-Gault formula. Now nobody calculates anything these days, right? We all have our mobiles. So this is something I just fed to find out what my GFR was, okay? And guess what my GFR is, okay? My age, my weight, my serum creatinine, my height, and I only have a GFR of 75 milliliters per minute. Now the reason I'm putting this is, when a lot of my postgraduates come and present PACs to me, they will say, Madam, he's 65-year-old diabetic, hypertensive, CAD, dyslipidemia. Okay, why is he CKD? What's his creatinine? Creatinine is 1.5. So remember, not all creatinine elevations are CKD. A CKD should only be diagnosed in the proper context. You have to have some pathological changes in the kidney suggest to a CKD. You should have albuminuria, urine sediment abnormalities, something that will tell you that the renal tubules are dysfunctional, or an imaging. Sometimes when you look at an ultrasound, they'll say loss of corticomedullary differentiation, right? Those are telltale signs that there's CKD. I do not have a CKD even if my GFR is 75. The Cockcroft-Gault formula tends to underestimate this value, although it is one of the most popular formulas used by nephrologists and intensivists. Okay? Now, the classification of CKD has actually changed a little bit over the past 5 years. To have a CKD, you may sometimes even have a higher than normal GFR of more than 90. But at this, you will have whatever I told you before, something to suggest a background of CKD. Now, I'm just cutting the numbers and making them round. 60 to 90 is called as mildly decreased. G3A is 45 to 60. 3B is 30 to 45. G4 is 15 to 30. And it's less than 15 ml per minute GFR is when you call it an end-stage renal disease. And even in that, some nephrologists would like to subdivide it as being dialysis dependent and not being dialysis dependent. Now, there is also another classification based on albuminuria. So there is an important ratio. When you look at patients now, you'll find that they're all looking at the urine albumin creatinine ratio. That is to see if the renal tubules have been damaged, particularly in the context of diabetes. The normal urine albumin creatinine ratio is less than 30 milligrams. If it's up to 30 to 300, they say it's moderately increased, and more than 300 is the frank proteinuria. You know that this patient definitely has tubular dysfunction and is excreting protein that he should not be. Now, what are the common causes of renal dysfunction? Why does a patient in India come for a renal transplantation? Now, heading the list, in the elderly population, you're most often going to find diabetes, or you may find atherosclerosis, dyslipidemia, rarely metabolic disorders. You know, you might find hyperoxaluria. Polycystic kidney disease is another, not very common, but not an uncommon presentation. What about CKD in the younger individual? Most often it is due to chronic glomerulonephritis of different forms. So remember, first, when you talk about a renal transplant, you should know why did the patient have renal failure. Is he an elderly? Elderly look at causes like diabetes, hypertension and those causes. In a younger individual, think of metabolic or congenital syndromes. Now, this is just an interesting slide that I picked up while preparing. If you see on the left, you're seeing a normal glomerulus, the basement membrane. The macrophages are represented in violet. You can just see there are 3. right? And there are something called podocytes along with foot processes. I'm not sure how well it's seen. It's like a little frill. Now, in a well-controlled diabetic who claims to be having a HbA1c between 6 and 6.5, he still will have an increased number of inflammatory cells inside. There is a loss of the foot processes as well as a thickening of the basement membrane. So what they were trying to represent is, why does diabetes cause CKD? And that is because even in the most gentlest diabetic, you have an underlying inflammatory process that is hidden, and these are probably changes, if left unsupervised, may progress to chronic kidney disease. So let me come back to our patient, right? We are going to have a 59-year-old male patient who's diabetic for 12 years, hypertensive for 8 years. For 2 years or 3 years, he's been known to have elevated creatinine and was managed by a combination of diet and medications. But for the last 2 years, he had to be inducted on hemodialysis, and at the point he presented was on twice weekly hemodialysis. He was on medications for his diabetes that had been changed largely to insulin and was getting a dose of both actrapid as well as an intermediate and long-acting insulin. And for his blood pressure, he was on 2 medicines, Arcamin and Nicardia. So how would I evaluate this patient? If this patient were going to, because my lecture says how to evaluate, I'm just going through it. One of the important systems we need to remember in any patient with CKD is the coexistence of hypertension. This hypertension is significant, high, often need multiple drugs to control, and remains largely uncontrolled. There have been patients where a preemptive nephrectomy had to be done for the control of hypertension, because beyond the 6 medications, the patient's BP is not getting controlled and he was going into hypertensive pulmonary edema. Right? Mechanism of this essentially is an activation of the renin-angiotensin-aldosterone axis. You have an increase in the extracellular fluid, and the consequence of this is that there is a left ventricular hypertrophy, because the heart, Dr. Anita spoke about this pressure volume loops. The heart has to work against a higher afterload. It hypertrophies, there's an increase in the muscle mass. When there's an increase in the muscle mass, there's an increase in the oxygen demand. So this upsets the oxygen supply demand ratio, and these patients may go into ischemia. Now, so in addition to this, patients with renal disease can tend to have a dyslipidemia, of which an elevated component of triglycerides is commonly seen. I'm not sure why, but they say an elevated triglycerides up to 600 is not treated in patients with renal disease. Other factors that could predispose to cardiovascular changes are dyselectrolytemia and acidosis, and these may increase the propensity for developing arrhythmias. So if I were, I'm of course going to ask for an ECG in this patient, I would look at a transthoracic echo. Specifically, I would look for features of left ventricular hypertrophy, a functional mitral regurgitation because of the left ventricular hypertrophy. The other thing is a elevation of the right ventricular systolic pressures, which is a surrogate of the volume overload. Right? If you know that the values of RVSP written by a cardiologist are anything more than 25 or 30 plus RAP, this means that there is volume overload and there is scope to improve the volume status by a little more efficient dialysis. The other thing that we need to look about is a global ejection fraction. So the ejection fraction, sometimes in the absence of localized segmental wall motion abnormalities, can be low. And this is a condition called uremic cardiomyopathy. This unfortunately is not age preferential. You may have a young 30 or 35-year-old having an ejection fraction of 35, no coronary disease. So this is something that you can only try to improve by doing dialysis. Some of these may return to semi-normality after transplant, some of them may not. And this is something we need to remember. The other thing that you look for an echo is any ischemic changes that may coexist in patients with CKD. Right. Can I just stop with the transthoracic echo? Now, there are new guidelines in 2022. So obviously, for all patients, for a young 35-year-old who's hypertensive, echo shows LVH and ejection fractions okay, you don't need to do anything further. But if you are looking at a 60 or a 50-year-old diabetic who may be obese, who may have a background of coronary artery disease, who has LVH that is picked up on an echo, or who has had hemodialysis for more than 5 years, they mention that presence of more than 2 or 3 of these risk factors should prompt you to go for the second level stress testing. Now, most patients with CKD have poor effort tolerance, will not be able to walk on a treadmill. So you don't have much choice but to do a pharmacological test like a dobutamine stress echo. And now at our center we tend to do a coronary angiogram which may be more complete, and we are not in any fear that the contrast given can worsen the nephropathy because the patient is already in renal failure. One thing that I have read and which may be of noteworthy is that adenosine is a common drug that is used for myocardial perfusion imaging. That unfortunately has limited value in renal disease because it is not capable of producing the coronary vascular dilatation that it should in a normal person. And a new tool for assessment of associated coronary artery disease is a calcium scoring. Calcium scoring is nothing but a simple CT taken of the chest. If you have to look at abdominal CTs and have cuts of the heart, you will see that some of the vessels are calcified, and that should prompt you to go for an assessment of a calcium score. So by the book, calcium scores of less than 100 are acceptable, 100 to 400 is this way, that way. More than 400, patient should ideally have a coronary angiogram. So I'm just telling you what should be done. All I'm telling you is a diabetic patient, don't stop with just a transthoracic echo. Look at the associated abnormalities and see the need for additional stress testing or a coronary angio as per the policies of your institute. Respiratory system. If the patient is well dialyzed, you're not going to have respiratory symptoms unless there is associated infection or a pleural effusion. But things that you can look for are any cardiomegaly associated with prolonged left ventricular hypertrophy, pleural effusions. You may or may not be able to do the 6-minute walk test, and we sometimes do pulmonary function tests and sometimes we don't. Other evaluations. A patient coming for transplants needs to be evaluated from every specialty. Endoscopy needs to be done to rule out ulcers or that's CLO, that infection, if H. pylori infections, which need to be treated. Any neurological evaluation needs to be done because a hypertensive patient may have thrown a stroke earlier. Angiography or at least an imaging of the iliac vessels needs to be done because your new graft is going to be placed and anastomosed to the iliac vessels. Thyroid function tests need to be done. A psychiatric evaluation needs to be complete because you need to know that your patient after transplant is going to be compliant with the immunosuppression and other medication. An ultrasound of the abdomen is usually done, and in this you need to specifically look for association of fatty liver. Mild fatty liver, grade 1 or even grade 2 is acceptable. Beyond that, it may be an issue that you need to look for possible correction because a lot of the drugs that you're going to give as immunosuppression have the propensity to worsen any atherogenesis and fatty metabolic liver disease. So coagulation is often spoken about when you talk about a patient with end-stage renal disease. Now largely coagulation is normal, but you must remember the specific abnormality is due to deficiency of von Willebrand factor and of factor 8. So if you have to place an epidural for any reason in a CKD, it should never be a contraindication. Right? Only thing is, if a patient with CKD is undergoing surgery and is oozing, then specifically giving desmopressin conjugated estrogen may help, or you can have to give cryoprecipitate because these are the clotting factors specifically which are decreased in patients with liver disease. Now when a patient with CKD is often on erythropoietin to help his hemoglobin counts. This actually reduces the bleeding time because it enhances platelet aggregation, and therefore you need to remember that it can contribute to hyperviscosity. It has also been known to be associated with hypertension and strokes with excessive use. Now briefly about the renal donor, I think the details of this is given in the notes that you are likely to receive. Today at my institute we mainly do laparoscopic donor. So we may or may not use an arterial line. So it's just a peripheral line and intubation. Before that, as analgesia, we now have started the practice of giving intrathecal morphine. 2 micrograms per kg given in 2 ml saline at L34 or L45 space works like magic. The patient really does not have pain. Only care you need to take is a renal surgery is not as painful as a colorectal. So do not exceed a dose of 200 micrograms. You may not have your patient waking up very well in that case, right? Key things while harvesting the graft from the renal donor are the use of fluids. You need to use up to about 4 liters of fluids before the graft is harvested. You need to give mannitol at the time of renal artery clamping. And the use of laparoscopy is a challenge to ventilatory strategies. Right. Now coming to our recipient. So you have this recipient, you worked him up and you found him acceptable and he's scheduled for a transplant. The immunosuppression for the renal recipient actually begins 2 to 3 days before. Now we have a combination of the tacrolimus as well as a CellCept and of prednisolone. So what is done at our institute is the patient gets tacrolimus 0.1 milligram per day in 2 divided doses from 2 days prior to the transplant, along with mycophenolate 1 gram twice daily. Now the key initiation of immunosuppression is with anti-thymocyte globulin at a dose of 1 milligram per kilogram, and this is given 12 hours before the transplant. Anti-thymocyte globulin is prepared from rabbit serum, is extremely antigenic and allergenic. So it is given very slowly and under cover. At the time they are giving it, they will give a dose of methylprednisolone 125 before and another 125 at the end of the procedure to avoid any anaphylaxis or allergenic reactions. So once the ATG is given, the rest of it is as per the OT protocol, and your only additional immunosuppression will be the methylprednisolone at graft implant. So instructions for the patient are, he is fasted from midnight the previous day for solids. All these patients who are on dialysis have fluid restriction. It may vary from 800 to 1 liter. It's important to ask the patient if he has any native urine output. That will tell you how liberal you can go in case you're giving IV fluids for a hypotension or for any other cause. We also give proton pump inhibitors because they are superior to the Rantac in terms of GI bleed. We make sure that the dialysis is done on the previous day, and 4 hours after the completion of dialysis, we ask for CBC, which includes hemoglobin platelets, we ask for creatinine, we ask for sodium, potassium, and make a request for APTT and prothrombin time. The request for APTT is in the background that heparin is used as the anticoagulation for dialysis, and we want to rule out any residual effects in case we are giving blocks the next day. So preparation for anesthesia. I hope I am clear to this thing. I can clarify in case you have doubts subsequently. So the patient is brought with these his medications, his hypertensive medications have to be continued. As far as insulin goes, the rapid acting insulin is given at the same dose before dinner, and the intermediate or long acting insulin is given between 2/3 to 3/4 of its dose at bedtime. So if it's a diabetic patient, you will check the fasting blood sugars, and there is a protocol that you can correct hyper or hypoglycemia. Now once your patient comes into the OT, it begins with starting in the IV line in the hand which is opposite to the hand that contains the AV fistula. What fluid am I going to hang up? Simplest fluid that we would like to hang is any balanced salt solution, and ringer lactate comes as the first choice. When would I not use ringer? You can also use plasma light. When would I not use either of these is if the potassium measured on the morning of surgery is more than 4.5. I don't want to overload the patient with extraneous potassium. So in this, what I do is to give half NS with bicarb. Now I've said this a few times, and I don't know, some of you may be familiar with my protocol. So 8.5% soda bicarbonate, if you take 1 ml, contains 1 milliequivalent of sodium. Half NS contains 75 milliequivalents of sodium per liter. If you add 75 cc of soda bicarb to 1 liter of half NS, your sodium value of the combined solution comes to 150, right? So that is an appropriate sodium volume to give, and you're not giving any additional potassium. The catch here, so that's why I said half NS, you give half of 75, which is 37.5. My only thing which I am still confused is what happens to the additional bicarb that I give. My normal ringer lactate contains 27 millimoles of lactate per liter, which means it gets converted to that equivalent of bicarb. But here I am giving 75 per liter. Strangely, when this is used clinically, it has not made any change in the acidosis or alkalosis. We are still doing a trial among liver patients. So I am not able to give clearer answers. All I can say is when we use half NS with bicarb sporadically in the background of elevated potassium, it has not contributed to measurable changes in acid base status. Right? Now, you can see on the screen, you have an arterial line and it shows 38 and 30. Any idea what's happening? The BP says 131/67. So this is nothing but an IV line that was accidentally placed on a fistula line that was accidentally placed on a fistula arm. So there is a arterialization of the vein that can remain. So we just felt the blood was spurting and transduced it, and this is what happens. So just be careful that whenever you're putting an IV line, you make sure there is no non-functioning, so-called non-functioning fistula on that hand. So how do I plan? Let's come back to our patient. He's now in the theatre. You put an IV line, his potassium is okay, you've started ringalactate. We need to put an arterial line either at or just at the time of intubation. You really don't need to put a pre-procedural line because the patient's hemodynamics are usually good. In fact, the blood pressure is on the higher side. So the thing you need to remember is that we try and preserve the radial artery because in case the graft fails, they may need it for a subsequent AV fistula. So the safest thing we do is to put a dorsalis pedis or a posterior tibial, but this has to be done on the leg opposite to the side where the graft is placed. Commonest side for placement of the graft is right iliac fossa, and you can see a left dorsalis pedis, right? And then is a picture of the central line. The central line and this were both placed after induction. Analgesic options for the recipient. Here again, you have a choice of putting it before or after. Now you can either, now what do we do today? We don't put epidurals, although at coagulopathy point of view, it is safe to put epidurals. The reason we don't put epidurals are, once you put an epidural and you're giving a local anesthetic solution, the BP is very difficult to control, either in or after surgery. Now, if the BP drops from say 180 to 110 and the graft doesn't function for some reason, this hypotension will be incriminated as a cause for a delayed or a non-functioning graft. So most anesthetists who do renal transplant don't put an epidural. Today with the ultrasound, we have all now moved to putting erector spinae catheters, right? Now I do it after intubation because I put a catheter. The picture on the right is not for a renal donor, it's actually for a liver donor. That's why you're seeing two. In a renal donor, you need to put the catheter lower down and you need to only put on one side and it works like magic, right? Once I put a catheter after induction, I give about 30 ml of 0.2% ropivacaine with maybe 4 milligrams of dexamethasone, and that more or less covers the responses during surgery. So regarding induction, because of interest of time, I'm just going to ask questions which I think you might be asking. Patient is hypertensive, may have CAD. Do I need to use etomidate or propofol? My vote would only be for propofol because these patients are really hypertensive, right? Now, if they are hypertensive, am I going to be needing labetalol or metoprolol or esmolol at the time of intubation? No, provided you give adequate analgesia like 2 mics per kg fentanyl with some midazolam and upturned with about 1 mg or 1.5 mg per kg xylocard. I have not seen the BP rise needing labetalol for intubation response. Next question, do I have to do rapid sequence induction for my liver recipients? So unless your liver recipients are not properly dialyzed, have ascites, or have any other reason for bleeding or whatever, you don't need to do RSI in a controlled, well-dialyzed patient. You can, of course, supplement this knowledge with measurement of gastric residual volume using ultrasound. Rough thing is, if the gastric cross-sectional area is less than 10, then you're safe and it's not a full stomach. Using 1.5 ml per kg may sometimes not work if the patient is very thin. You may have a cross-sectional area of 5 or 6, but if the patient is 35 or 40 kgs, it may cross that value, right? If I give fentanyl or whatever, will my patient not wake up because analgesics have not been eliminated? In today's era and with the use of fentanyl, I have not come across this situation. Even if the graft were slightly dysfunctional, you're unlikely to have a problem. Now, using a bispectral index and monitoring the depth of anesthesia and titrating your agents appropriately may help. When they started using BIS and kept appropriate inhalation, the fentanyl infusion that was previously a protocol just vanished. Neither was there fentanyl nor was there atracurium infusions in our patients, which is fine. Muscle relaxants, again, I have the same answer. They are all ultra metabolized by esterases and non-organ dependent elimination. So if you use Atrac or Cis-Atrac, it's very unlikely your patient's not going to come out of the relaxant effect. Now, unlike other surgeries where they say CVP is trash and you cannot rely on it, in a patient undergoing renal transplant where there's no output to corroborate your hemodynamic status, CVP remains the best available option to tell you about fluid status. Now, if you felt still that the CVP is not the monitor you want to trust, you can use minimally invasive cardiac output monitors that are based on a pulse contour analysis. If you want to know what the profile of the cardiac output would look like, cardiac output would be normal or slightly high. SVR is going to be normal. And then if your SVV or PPV is less than 10 or 12%, you're probably adequately volume loaded, right? So this is just a picture to tell you what one could have. This again is not from a renal transplant. You can see the pulse contour, bispectral index, this is a monitor, and the right side is a screen. Now there are two arterial lines, it was used for a liver, and this is not a renal recipient. So how would I use my blood gases? We have a dorsalis line. Definitely I'd like a baseline blood gas to tell me what my potassium is. I also will know how much my bicarb is for a start. The second blood gas is usually done when they take the graft from the donor and then begin to start the implant. So key things at that point are giving a triple infusion of mannitol 20% 100 ml, furosemide 80 milligrams, and methylprednisolone 500. So if you think that the dose of methylprednisolone is a little less, remember that about 250 to 350 has gone the previous night, right? And there would be an additional dose that will give once a nephrologist receives this patient in the ICU. The only thing that I'd like to say is do not mix mannitol with other drugs because it tends to form a precipitate. So you can see in the picture, the kidney is actually placed in a pocket in the extraperitoneal tissue, which is why they say that a patient with transplant should not get into sporting injuries because a kick on his lower abdomen could damage the graft. So the anastomosis begins with the anastomosis of the renal vein of the graft to the external iliac vein of the recipient. And then when they do the renal artery, that's when reperfusion happens. So what should the anesthetist do at the time of reperfusion? Key things they say is keep the CVP at least 10 or 12 millimeters of mercury at the time of reperfusion. Now when I do a transplant, normally I may give anywhere between 3 to the 4th pint of fluid to keep the CVP this way. And the choice of either ringalactate or half NS is based entirely upon the potassium. Right? If the potassium, despite you giving half NS, tends to be high, now that can happen in patients who have tubular dysfunction, you need to be prepared to handle hyperkalemia with boluses of calcium, GI infusions that are needed to be given, and sometimes bicarbonate. These are the three things you need to be. Does a patient bleed? Transplants usually don't bleed very much unless there are technical vascular issues. You can keep blood, have a very high threshold to transfuse because transfusion just increases the incidence of rejection because of antibodies against the leukocyte. Leukocyte antibodies against the graft. So you only give when needed. Make sure they are leukocyte depleted and if possible irradiated because they will reduce one incidence of rejection and two graft versus host. So this is a picture when the artery and the vein have been anastomosed and reperfused. The anesthetist will be able to see urine coming from the ureter. And there would be a request from the surgeon to make sure enough volume is given so that the graft kidney feels turgid. Right? So once you see urine coming, the job is done. Then it is the surgeon's anastomosis of the ureter and the completion of surgery. Now, this process can take anywhere from 4 to 5 hours. So if it takes that much time, you can perhaps repeat your second dose of local anesthetic infusion through the ESP catheter at this point. I would give 20 ml at this point, and this should cover the analgesia at the time of extubation. Right? Post reperfusion, you definitely need to do a blood gas. Make sure your potassium and metabolic status is okay. Keep the CVP filled. Watch for any bleed. And I said, as I've already said, you can repeat the 20 ml just before the extubation or at the time of closure. And the further orders are usually give 20 ml every 4th hourly in the ICU. So when it works like magic and they don't need any additional opioid. Sometimes they may need opioid at the time of extubation. But I think those are more with technical rather than the effect of an ESP catheter. So I would be finishing up at this point. I'm going to sum up the key points in intra-op anesthesia. One is fluid management for the recipient. Keep it low because he doesn't have output initially, but when they are going to perfuse, maintain a CVP of 10-12. It's important to maintain the blood pressure. The mean arterial pressure in a renal recipient should be above 90 or even 100, not 65 or 70. Right? Remember the triple cocktail that is given when the graft is implanted. Do not mix mannitol with other medications. It will precipitate. The role of ABGs in management of reperfusion, and watch for hyperkalemia after reperfusion. Post-operative care, if the surgery has gone on with the kind of speed with which I have spoken, no, if it goes on smoothly, you really don't have any reason not to extubate. Your reason for extubation follows a certain style. Hemodynamically stable, minimal or no supports, metabolically stable, no hyperkalemia, functioning graft, no bleed. Temperature is okay. Then you can go ahead and extubate the patient. The fluid management post-procedure is at the discretion of the nephrologist, who tend to give a certain calculation. If the urine is less than 500, they give urine output plus an additional 500. Between 500 and 1 liter, they give match the output. And if it's more than 1 liter, all this is per hour. They reduce 500. So it's an extraordinary amount. I asked them this question. We are talking about excessive fluids damaging the vascular endothelium, stimulating the atrial natriuretic peptides. So why are we doing this? But I guess they have their reasons. They didn't come out with clear answers, but they did say they are trying to move away from normal saline to more balanced solution. That was the closest I could get with them. Hypertension continues post-operatively. This patient will need antihypertensive. And maybe on the next day they are allowed to ambulate, and feeding is restarted at a time when Dopplers are okay and the patient looks comfortable. Immunosuppression will have to be continued post-operatively. So I am summing up. This is a picture of a dessert. This is not an egg, but a dessert that was panna cotta, which was served so beautifully. So I hope I put in a nutshell some of the things that you might have in use for your future. Thank you.
Thank you, ma'am, for your insights on the approach to managing a case of renal transplant. The floor is now open for discussion.
Excuse me, ma'am.
Yeah, go on. I can't see you. I thought I saw you.
Recently, we had one case, I think 1 year back, same renal transplant. Recipient had known case of infective endocarditis.
Ouch.
And the ejection fraction was around 30-32. Same intra-op, again, the surgeons asked for a high CVP of 12. So in that situations, what is the fluid management?
So I think there's something wrong in what you're saying. Neither should a patient with infective endocarditis nor somebody with an ejection fraction of 35, which is due to coronary artery disease, is a contraindication. Right? Infective endocarditis, unless controlled, should not be a candidate for surgery. Right? If it is uremic cardiomyopathy and they have an ejection fraction, you still can give. The patients usually don't go into failure at that time.
Good afternoon, ma'am.
Yeah.
My question is that you told me that qualitative platelet dysfunction shouldn't stop you from epidural.
Nothing is a problem in renal recipients.
So
no.
only the hypertension is our concern. That
Yes.
ma'am, in your institute, you don't.
We don't put epidurals. We started at the beginning. This is in 2001,
Okay.
and the surgeon was, the nephrologist was unhappy, so we stopped.
Okay, ma'am.
They preferred opioids, but now with ESP, we use ESPs with a fair degree of comfort. It's not as good as an epidural.
Okay. Intrathecal morphine, ma'am.
Yeah, now intrathecal morphine has been used in some centers where they found some problem. So because of that, I didn't use it. You could probably try. I'm not sure what the problem was. They didn't disclose it to me. Okay. So I think it can be used, but remember it will last for 24 hours.
Yes, ma'am.
In a lap surgery, it's okay if that's 24 hours because the pain is not there very much after that. This is an open surgery. I think it can be used. Maybe at a lower dose, you might find it quite useful.
Thank you, ma'am.
Moving on, the next session is a case discussion for severe pre-eclampsia. We welcome Dr. Alexander Phillip, consultant anesthetist at East Suffolk and North Essex NHS Foundation Trust Colchester, UK. His areas of expertise include obstetric anesthesia, difficult airway management, orthopedic and regional anesthesia. We are honored to have him with us today to moderate this case discussion on severe pre-eclampsia. I would also like to welcome Dr. Priyanka Kini, Associate Professor at KMC Manipal. Dr. Priyanka holds a fellowship in pain medicine and has authored numerous articles in index journals, and her primary expertise has been in managing acute and chronic pain. The speakers for this session are Dr. Manoj, Junior Resident KMC Manipal, and Dr. Samriddhi, Junior Resident KMC Mangalore. I now hand over the floor to the moderators.
Nice to see that Manoj has a lot of support in the audience. Okay. So this is the scenario that I had given to the two candidates like a couple of weeks ago. So I hope 2 weeks was enough to prepare. It's a big topic. It's a multi-system disorder. So I will carry on without wasting much time. So when you went through this scenario, would you agree with me if I say that this fits the picture of a patient with pre-eclampsia with severe features? Is that fairly... what are the features that suggest a severe disease here?
Sir, first thing is the blood pressure, sir.
Yeah.
For a criteria for severe pre-eclampsia, it should be systolic more than 160 and diastolic should be more than 110 millimeters of mercury.
Yeah.
And one signs of end organ damage. It will be seen here as central nervous system, that frontal headache and photophobia history is there.
Yeah. Okay. So when you're reviewing this patient along with the obstetrician, what is your primary concern, your number one concern?
So since she already has imminent signs, after discussing with the obstetrician, what my primary concern for her is that we can't go for an expectant management for her.
Yeah,
that
expectant management at this point is not required. So
not required. Yeah. For her,
so what would be your number one priority?
That she should not go into an eclamptic fit.
Yeah.
Because,
okay. Yeah. Okay. Agreed. Okay. So tell me about that. What is your plan to prevent eclampsia?
So because already the patient has imminent signs of she has severe preeclampsia. So with like in our institute, with the obstetrician, I would like to discuss what their plan is, because they usually start with an antihypertensive, which is usually what we follow is a calcium channel blocker. Also, they have to start around Pritchard regime that is followed in our institute. We start the patient on magnesium sulfate, 20% loading IV, 4 grams IV. And
just tell me the magnesium regimen, because that is quite important.
The Pritchard regimen we follow, sir. Yeah. It's 20% 4 gram intravenous loading dose and 50% 10 grams in the IM in the buttocks. Then we continue.
The loading dose is over what period of time?
The IV is over 5 to 10 minutes, sir.
Okay. Yeah.
And then we maintain it with intramuscular 5 grams of 50% max self in alternate buttocks over 4 hourly.
So maintenance you give intramuscularly?
Yes, sir. But if she has already thrown a seizure or recurrent seizures are there, then we have to continue IV 2 grams and that we can give 2 to 3 hours, 2 to 3 hourly.
So I'm assuming that you don't follow a system of an infusion for magnesium maintenance?
No, sir. In our institute, we don't.
What about you, Manoj?
Here we are following suspend regimen, sir.
Yeah, okay.
So 4 grams first IV for 5 to 10 minutes, followed by 1 gram per hour infusion will be starting IV.
For how long?
For 24 hours post-delivery or 24 hours post-last seizure, sir.
Fine. Okay, that's fine. How do you monitor a patient who is on magnesium therapy?
So first we need to find normal therapeutic value, sir. It should be 5.9 to 7.4. So if it is
5.9, 7.4 what?
Milligram per deciliter.
Okay.
If it is
always say the units, yeah.
Yes. Yeah. If it is more than 12 means there will be a loss of patellar reflex, and if it is more than 12 to 20, it will be respiratory depression. If it is more than 25 milligram per deciliter means there will be a cardiac arrest.
Okay. For a patient who is on magnesium therapy, what are the implications if that patient goes for an anesthetic?
Sir, if main concern is magnesium itself, if at all patient land up with suppose GM means, my main concern will be it is prolongs the action of non-depolarizing muscle relaxant. So that will be a main thing. And one more thing is the magnesium sulfate itself is a tocolytic. So that also might be there. And the magnesium with suppose on nifedipine means that itself causes synergistic effect. So that itself causes hypotension.
Okay.
So that will be my concerns.
Magnesium therapy is one of the things you have started. I think you have also started antihypertensive therapy. What else do you want to do?
Because she is a severely pre-eclamptic patient, I want to assess the hydration of the patient, because these patients are fluid depleted.
Yeah.
So according to that, I want to start her on IV fluids or see if she needs that. Secondly,
What would be the recommended infusion rate?
so what we follow is not more than 80 ml per hour, but that depends on what kind of signs the patient is showing.
Yeah.
Suppose the patient is in oliguria or the patient has signs of renal dysfunction. I want to know, is it because of the hypovolemia? So I'd like to, if that's the case, I'd like to give her a fluid challenge of about 250 ml. If it improves with that, I'll continue the same. I'll continue fluid resuscitation, or else I would restrict the fluid therapy.
Okay, so magnesium, antihypertensive therapy, what else?
Antihypertensive therapy,
Yeah.
then oxygen supplementation, sir.
Yeah, okay.
Rest conservative.
Have you done any bloods? Have you done any blood investigations?
No, that yes, sir. For preoperatively, I'd like to go for that, because if
What would you like have done?
a complete blood count,
Yeah.
to know about the hemoglobin of the patient, and to know about if it's a hemoconcentrated state, because usually preeclampsia is a hemoconcentrated state. Then about the platelet count of the patient, because it's a hypocoagulable state, and these patients are
Hypercoagulable state.
hypocoagulable state.
Yeah.
And these patients commonly present with thrombocytopenia. Secondly, I'll want to know about the coagulation profile of the patient. Then thirdly, about the renal and the liver functions, because
Okay.
that can be deteriorated in these
Okay,
patients.
so let's say a few hours go by, bloods have now come back, everything except the platelets is normal. Platelets, let's say, is 95,000 per cubic per microliter, okay? That's just a value. Other bloods are all normal, okay? Blood pressure is now 135/87. But on cardiotographic monitoring, the patient is showing some reduced accelerations, okay? So obstetrician wants to take to theatre. What is your perioperative plan?
So my perioperative plan will be, first I'll see my patient, I'll introduce myself to my patient, I'll explain her condition and my plan of anesthesia, and take an informed consent from her. Because you said that the blood counts, everything is normal, and platelets are more than 95,000 per microliter. My plan will be regional anesthesia, which also I would explain it to her.
Which would be what?
Sorry, sir?
What technique of regional anesthesia?
Spinal central neuroaxial block, it's spinal anesthesia.
Okay, yep.
That also I'll explain to her, like what the procedure is going to be.
Yeah.
Then take an informed consent.
Yeah.
Then take her to OT.
Have you examined the airway?
Yes, sir. Airway also I'd like to examine it.
Why is that particularly relevant in this case?
Because these patients are prone to developing airway edema, sir.
Okay.
If at all, if the case goes into a general anesthesia, airway manipulation can be difficult in these patients. They have increased capillary friability also,
Okay.
which can cause which can traumatize the airway easily.
Okay.
And other thing is that intubation and scopy can be difficult,
Yeah.
and they're obviously, because it's a pregnant state, there's increased risk of aspiration.
Okay, Manoj, take me through the spinal piece. The spinal anesthetic. Take me through the spinal anesthetic. How would you do the spinal anesthetic?
Okay. Sir, first thing, that NPO status and all I explained,
Yeah,
sir.
yeah, that's all fine.
So, BP is 130/80.
Yeah.
So, platelet count is 95,000.
95,000.
95,000.
Yeah.
So, if at all I'm going for regional blockade means, first I will explain the risk. Because first I need to find out when the platelet has done. So, I need
it's
first I need
within
to
2 hours.
So within 2 hours, I will definitely go ahead with this thing, sir.
Yeah.
So regional. So also I explained one word on that epidural hematoma also explained, sir. So I will be after monitoring, then restricted fluid co-loading, then patient baseline vitals. I will position the patient in the left lateral position. Then
What is the solution you're going to use for the spinal?
0.5% hyperbaric BP vaccines.
Yeah. Volume?
For this patient, I will take 1.8 ml, sir,
Okay.
and 60 micrograms of buprenorphine.
Is that standard protocol here in Manipal? Buprenorphine? Oh, okay, that's fine. Okay. And how will you test the block?
First, sensory level I will check, sir. I need at least a T4 level blockade for the cesarean section.
What do the 2022 guidelines from the Association of Anaesthetists say regarding testing of block?
Sensory blockade up till T6 is.
T5.
T6 is.
That's for what modality of sensation?
Touch can be present.
Fine touch, yeah, fine touch. Second modality only if there is doubt for the first one? Yeah?
Yes.
Okay. And absence of straight leg raising
Yes.
to confirm motor block, okay?
Yes.
What are the other things that you normally do? So oxytoxics, what are the choices of oxytoxics in this case?
So what we follow is intra bolus dose of 5 units of oxytocin, and usually 15 units in the IV fluid or 20 units of IV fluid, international units in the IV fluid of oxytocin.
Which oxytoxic would be contraindicated in this scenario?
Methylergometrin.
Ergometrin, okay. Post-op management?
Post-operatively, sir, these patients have to be vigorously monitored for their blood pressures and urine output, because up till 48 hours we consider the patient to be in a critical time period. Up till 48 hours we consider that still the patient can develop a pre-eclamptic fit or can go into eclampsia.
Okay.
So I would want the patient to, because while the patient is under regional anesthesia, we have strict control. We have control of BP, but as our regional anesthesia starts to wear off, these patients can again develop uncontrolled hypertension.
Okay,
So
fine.
I'd like to manage that, and good post-op pain relief and fluid therapy and strict urine output monitoring for these patients.
Ideally in a high dependency kind of a setup. Okay. I think we'll close the case discussion there. If you can just bring on, I'm doing a brief presentation just highlighting some of the important points in pre-eclampsia. So you can just bring that up, please.
So I'm just going to summarize some of the key features. Most of them Samriddhi and Manoj have already mentioned. The most important thing about pre-eclampsia is that it's not a one-man job. It's a multi-system disorder. So you involve a lot of specialists that are in your hospital. If you're working in a predominantly obstetric center, it's always a good idea to have a good working relationship with all of these people. Other than, of course, obstetricians, cardiologists, hematology, neonatology. In the UK, of course, we involve the midwives as well in this plan. Depending on what publication you read, optimal BP is approximately sort of 130/80, that kind of ballpark figure. Early anesthetic involvement needs to be there, so airway assessment, very important, hemodynamic status, sending off bloods for coagulation parameters. Remember that as labor proceeds, the airway edema may worsen. There may already be airway edema in situ when you see this patient, which is why GA can be very, very tricky. With regard to the platelet count and insertion of epidural for labor, there is no consensus as to what is a safe number. There's also no consensus about what is the recommended duration between the last set of bloods and the point that you can insert the epidural. But generally, a value of 70,000 per microliter is taken as an okay value. The incidence of epidural hematoma at that value is less than 0.2%. So it's probably safe to do it at that level. Less than 50,000, I would not do a labor epidural for that patient. Fluid restriction, as Samriddhi said, 80 mils per hour is the recommended value. And that includes not just the IV fluids, but all the infusions, oxytocin, whatever else you are giving, it's included in that. Neuraxial techniques are preferable both for labor and for C-section because GA can be very, very dicey. You may not even be able to get a tube in because of the swelling. Prophylactic, I didn't bring this up at the discussion, but titrated low-dose phenylephrine is the best option to prevent spinal anesthesia-induced hypotension. 50 mics, less than 50 mics per ml infusion. Bolus also, normally I would use a bolus of 100 mics for a patient for phenylephrine, but for pre-eclamptic I would decrease that to 25 or even 50 mics. If a GA is deemed to be necessary for, let's say, fetal compromise, the cardinal point is to blunt the hemodynamic response. Without that, you risk causing a stroke or an intracranial hemorrhage. My personal choice is remifentanil, 1 to 1.5 mics per kilo of remifentanil, but use whatever is available in your institution. Anything is acceptable. Lignocaine, labetalol, fentanyl, alfentanil, whatever you have is acceptable. But you have to be seen to have blunted the response. Otherwise, you might be held criminally negligible. Okay. If magnesium has been started pre-op, then it's necessary to continue it in the post-op period. As Manoj said, take care with the non-depolarizers and use quantitative neuromuscular monitoring. Get a T4 by T1 value more than 90% before you extubate. And use Sugammadex if it's available. I believe it's now reasonably freely available in India. I just want to, this is a little bit of obstetrics. It's basically a new ratio which you can help with early diagnosis and surveillance of preeclampsia. So if you go to the pathogenesis of preeclampsia, it is basically an imbalance between pro and anti-angiogenic factors. So the placental growth factor, you guys must have read about this. Yeah. So placental growth factor is basically a pro-angiogenic factor. And the FMS tyrosine-like kinase is an anti-angiogenic factor. So when you have an imbalance between these two, the ratio becomes a very useful marker for early diagnosis. So the cutoff value is 38. Less than 38, generally we say no preeclampsia. More than 85, very likely to have preeclampsia. But between the two, there's no definite diagnosis, but it's likely that within about 4 weeks, that patient will develop preeclampsia. So that helps you to, how do I say, bring that patient in for a bit more closer monitoring and more frequent consultation with obstetricians. Okay, so that's the ratio. And I just want to mention remifentanil PCA for labor analgesia. Dr. Basanth is doing a talk on PCA following us, but I just thought I'll mention this because this is specific for labor analgesia. Very useful for preeclamptics who cannot have an epidural for low platelet reasons. So we start Remi-PCA for them. I'll come to the protocol. The advantage is it basically matches the time course of labor because it has a rapid onset and offset. It takes about 20 seconds for it to reach, in one arm brain circulation time. Non-cumulative in the mother and the baby. So very, very few extended maternal or neonatal side effects. There's a transient loss of variability in CTG, but this is less frequent and is not clinically a big concern. And certainly when compared with pethidine, which is till a few years ago was quite common in the UK, it produces better pain scores. Mother is definitely more satisfied. Less episodes of maternal desaturation and fewer effects on the baby. And this was confirmed by the respite trial in 2018. Okay. So this is a snapshot from the protocol that we use in my hospital. The consent, we say that it's the remifentanil's use in labor analgesia is not part of its UK license. So Remi's use in labor analgesia is an unlicensed indication. So we tell that to the mom. But tell that, there's a long history of safe use. There are hospitals that have had thousands of cases of REMI use. We tell them that it's not as effective as an epidural, can cause some sedation, itching, nausea, which you would expect from an opioid. Very rare chance of fetal compromise, and the mom may occasionally need supplemental oxygen. Contraindications would be high BMI. Twins is a contraindication because you may need the second twin to be delivered by internal version. So you need the mom to be more with it, so to say. So we don't use it for twins. Allergy to REMI is quite rare. Intrauterine death, there is no particular advantage of using REMI, so we just use morphine, morphine PCA. There is no advantage of using morphine. Long-acting opioid within the last 4 hours is also a contraindication. Large BMI, large patients, and a history of OSA or airway abnormalities also we don't use REMI PCA. So the midwife basically gets the equipment ready, self-inflating bag, and all the emergency kit is there. The single most important thing in this entire program is the continuous presence of the midwife with the patient at all times. So we cannot, if the labor ward is particularly busy and they are short staffed, then we cannot start it. Standard sort of monitoring, continuous pulse oximetry, heart rate, respiratory rate, etc. Is basically to do a verbal consent. We don't do a lot of written anesthetic consent in the UK, it's mostly verbal. Ensure that the staffing levels are appropriate, set up the pump, explain to the patient how to use it. Only the patient is allowed to press the pump. I'll just go back one slide. The pump is a Fresenius Kabi Agilia SP pump. So it's a pump that does not allow you to deliver additional, there's no background infusion or clinician bolus options. It's only the patient can press it. In terms of the setup, we have three protocols, 20 mics, 30 mics, or 40 mics. 20 mics is if the patient is less than 50 kilos. 30 mics is the commonest protocol with a 2-minute lockout. We adjust the bolus dose according to the response. If we find 30 mics is not enough, we have the option to increasing it up to 40 mics, again with a 2-minute lockout. It's a dedicated 20-gauge cannula. Nothing else goes in through that. We don't use any, we use an anti-siphon valve, anti-reflux valve with no bionectars or anything connected to that. Opposite side of the NIBP, we avoid putting it on the wrist or on the antecubital fossa because they can kink. Use a do not use sticker to the cannula so that nothing else goes in through that. At the end of the use of the once the mom is delivered, we just take out the cannula. We don't flush it because you don't want to push more REMI into the system. As I said, we also give regular IV ondansetron and omeprazole as well, along with the package. We have to hand over to your colleague at the end of your shift, and generally support the midwifery team in delivering the service because they are our midwives are not doctors. They are experts in their field, but this is more our thing. So we have to support them. It works well. Our midwives are very happy because we are now able to offer this to moms who would not have had any form of analgesia otherwise. So they are very happy with it, and they always look out for the patient. So when we mooted this service, they were very happy to support us. So as you can imagine, there's a significant period of training and orientation before we are able to roll it out. But it's now working very well, and we are now having mothers coming to pre-assessment saying that when I come for my labor, I don't want you to stick anything into my back. I don't want you to paralyze me. I want REMI. They have read on the internet, and they would like to go for REMI. They are happy to accept that it's not a complete form of analgesia. They said just take the edge away. That's what they say, and they're happy with that. And I think that's all I had to say, really. Thank you.
The floor is now open for discussion.
Yeah. The unlicensed indication is technicality, really. I mean, because if you put it that way, in the UK, even fentanyl intrathecal is unlicensed, but we use it. As long as the use of that drug by whatever route has a long established record of safety, it will stand up in a court of law. So it's fine, yeah. But we mention it because otherwise it might be queried later.
Or whether obstetrician is
No, so the fetal bradycardia is not a given. It may happen, but it still stays within acceptable limits. So they are not too worried.
Because many times obstetricians are worried when your analgesia, epidural analgesia itself gives good relaxation, and so they are worried about that also.
And it is particularly seen in CSE for labor.
Yes.
You have this profound bradycardia that can occur because when that sudden sympathetic impulse is just suddenly damped down, you can get severe bradycardia. But it's not clinically, it's not a big thing that we see.
We thank our moderators for the session,
Thank you.
Dr. Alexander Philip, Dr. Priyanka Kinney, and the speakers, Dr. Manoj and Dr. Samriddhi. It is a great honor to welcome Dr. BASANTH Rayani, Head of the Department of Onco-Anesthesia, Pain and Palliative Medicine at Basavataragam Indo-American Cancer Hospital and Research Institute, Hyderabad. Dr. BASANTH is also an honorary fellow in SOAPC with an impressive record of 6 textbook chapters and 38 publications to his name. His areas of expertise include onco-anesthesia, surgical critical care, and quality in clinical care. We are privileged to have him join us today for his video session on how to set up a PCA pump. Over to you, sir.
Good afternoon, everyone. It's indeed a privilege to be part of APGAP 2024, and I thank the organizers for the opportunity. Over the next 25 minutes or so, I would talk on how to set up a patient-controlled analgesia pump. We would look at the basics of patient-controlled analgesia on and then how to set up a PCA pump. It was supposed to be a video presentation, so I would be showing 2 videos on setting up of a PCA pump. We'll discuss about monitoring and an analgesic prescription for 2 patients we will look. Patient who's on round-the-clock analgesics, in case he has pain, to call the nurse, get an analgesic, and have decent analgesia would sometimes take around 35 to 40 minutes. And this pain cycle may repeat every 3 to 4 hours, leaving a very poor experience for the patient. So a need-based, patient-controlled analgesia boluses, which are frequent, in theory eliminates this patient pain cycle. So in patient-controlled analgesia, a patient has autonomy and he is given charge of his or her self-pain management. This is a schematic diagram of the PCA pump. The physician decides what drug to be used and the concentration. He sets the demand dose and the lockout interval. There's a microprocessor which controls the pump. There is a display which shows the parameters and the total amount of drug consumed. There are alarms. And the pump is activated by the button, and whenever the patient presses the button, the microprocessor ensures that a fixed dose of drug from the drug reservoir is delivered to the patient. So this is basically how a PCA pump works. The pharmacological principles of IV PCA were brought out by Austin et al. In the year 1980. They spoke about minimal effective analgesic concentration and the minimal toxic concentration. So the area between these two, the MEAC and the MTC, is known as the analgesic window. So whenever you give a loading dose of drug, it brings up the serum concentrations to the analgesic window, and every time the serum concentration drops, the patient takes a PCA bolus, and the drug concentration reaches back to the analgesic window. But we need to remember that the log dose response curve of IV opioids is not linear. It is a steep sigmoid curve, and whenever the drug concentration reaches the flat portion of the curve, even a small increase in the serum concentration can result in significant opioid-related problems such as respiratory depression, especially in the patient population such as the elderly and the obese patients. So coming to the basic terminology, the initial dose of medication which is administered prior to initiating the PCA is the loading dose, and the pump is activated by the patient pressing the remote activation button, and each button press is called an analgesic demand, and the dose of drug that is delivered when the patient presses the demand button is called the demand dose. A set background infusion which is independent of patient demand is the continuous infusion. We have already seen that it is used to maintain the minimum effective analgesic concentration. It is used in patients who have poor pain control and those who are needing frequent boluses. It is compulsory in patients who are on prior opioid medications. It is important to remember that in opioid-naive patients who are receiving IV opioids, a continuous infusion should be avoided because there is a higher risk of opioid complications. The set time interval between two demand boluses is called the lockout interval. So even if the patient presses the demand button within the lockout interval, it does not deliver a next dose of drug. This is to avoid a dose of drug before the already delivered drug reaches the peak effect. Breakthrough pain is acute pain that occurs in spite of an effective PCA, and clinician-guided boluses can be used to treat breakthrough pain. It is normally clinician-guided and is administered by the nurse. Most modern PCA pumps have 1 hour and 4 hour dose limits. They are considered to be safety limits, but there are no clear guidelines on these limits. They usually set at 80% of the maximum dose of opioids that are to be administered. Hydromorphone is the most preferred drug for adult PCA, but it is not available in India. Morphine is the one that is most commonly used. Fentanyl has a peak effect of 6 minutes and it is rapidly acting, so it is used for acute PCAs, and it is used as an adjunct in patient-controlled epidural analgesia. Remifentanil PCA, Dr. Alex has already discussed about it. Local anesthetics are used in PCEA. Adjuncts such as ketamine could be used along with the opioids. They can be added to the pump, or you could set up a separate IV infusion of ketamine. So the PCA, when it was initially initiated, was as a standalone modality, but the present day practice is PCA pump as a part of multimodal analgesia with the IV analgesics such as paracetamol, IV lignocaine, ketorolac, etc. So these are the initial settings for an IV PCA. Morphine demand bolus of 1 milligram with a lockout interval of 10 to 30 minutes, a 1 hour limit of 4 milligrams. A clinician bolus of 2 to 4 milligrams, and the clinician bolus could be repeated every 2 hours. Fentanyl, a demand dose of 10 mics with a lockout interval of, again, 10 to 30 minutes. And a continuous infusion, as we have already discussed, is avoided in opioid-naive patients. But a continuous infusion could be used in patients on prior opioid therapy. And to determine what dose needs to be used, you calculate the equianalgesic dose of opioids in the patient divided by 24. And that decides the hourly basal infusion rate. You titrate it by starting with 1/3 to half that dose. Unlike IV PCA, patient-controlled epidural analgesia, a continuous background infusion is normally used. This is basically done to maintain the segmental sensory block. Low concentration local anesthetics such as 0.1% bupivacaine, levobupivacaine, or 0.1% ropivacaine with 2 mics of fentanyl is the common solution that is used. There are no standard dose regimes recommended for epidural PCEA, but these are some of the normal doses that are used in various institutes based on their local protocols. So this is the first video which shows one of the PCA pumps that we commonly use in our institute.
This is the rhythmic evolution PCA pump from Micrel. It consists of a display and keys for various functions. On one side is the DC adapter and a lock. On the other side, we see a port for connecting the demand bolus handset. The consumable is a reservoir bag with a capacity of 200 ml and unidirectional infusion set. Here we are loading 1000 mics of fentanyl diluted with normal saline to a concentration of 5 mics per ml into the reservoir bag.
Preloaded bags.
And the bag is labeled.
Preloaded bags of the drug are available.
Unlock the pump. The reservoir is placed in the compartment. Lock the pump to avoid tampering. Connect the demand bolus button to the port provided. Switch on the pump using on or off key. Enter the safety code that allows you to do the settings. Press enter. There are various modes of infusion available in this pump. We chose bolus only as the patient is opioid naive. Press enter. Select the appropriate units for the concentration of drug. We selected micrograms. Enter the fentanyl concentration 5 micrograms per ml. Press enter. Select the demand bolus dose of 10 mics. Lockout interval of 15 minutes. Four-hour dose limit as 120 mics. Total volume to be infused in 24 hours as 150 ml. Press enter. Review the settings. Prime the pump by pressing purge key for 3 seconds to remove air bubbles. Place the pump in the bag provided. It is now ready to use. Hang it at the patient bedside and under aseptic precautions connect it to the dedicated intravenous line. Educate the patient on how to use the pump. To run the pump, press start key twice. To give clinician assisted bolus, stop the pump, choose program, enter safety code, press enter, select clinician bolus, select the volume to be delivered, press enter, press start key twice for the bolus dose to be administered.
This is a different
This
pump.
is the CAT Legacy PCA pump. It has a display and keypad with keys for stop start, enter, priming, lock, next, on and off, clinician assisted bolus dose key, and keys to scroll up and down. On one side is the power jack, accessory jack, and an air detector port. On the other side, it has a lock. At the back is a battery compartment. And at the bottom, it has hinges for cassette. The consumable is a cassette with reservoir of 100 ml and an extension set. We are loading 0.1% bupivacaine with 2 mics per ml fentanyl for patient-controlled epidural analgesia. The drug is loaded into the cassette and labeled. Unlock the pump. Connect the loaded cassette. Lock the pump to avoid tampering. Connect the extension. Switch on the pump using on or off key. It runs a series of self-tests initially. Enter the reservoir volume choosing appropriate units, which shows milliliters. Press next. We selected a continuous dose of 8 ml. Press enter and then next. Demand dose of 6 ml. Lockout interval of 30 minutes. Press enter and next. Once the settings are done, press the prime key for 3 seconds to remove air bubbles. The circuit is primed. Connect the handset. Place the extension in the air detector port and pump is ready to use. Place the pump in bag and hang it at the patient bedside. Under aseptic precautions, connect it to the epidural. Press start key for 3 seconds to run the pump. we can review the settings again before the pump starts running. Once the reservoir volume is empty, it gives an alarm. Stop the pump, review the pump for the settings, doses delivered and doses attempted. This is how we review the pump before reloading the drug. Let's see some troubleshooting. If the extension is clamped, it gives a high pressure alarm. At this point, stop the pump, remove the clamp. The extension also has a unidirectional valve. If you connect the wrong end or other way around, the pump would not be able to deliver the drug. So it gives a high pressure alarm. If you connect the right end, the alarm is off and the pump is running again.
Right, I think I have a little more than 5 minutes, and I have 2 case capsules to present. The first one, we have a 58-year-old gentleman with a carcinoma colon and obstruction for emergency right extended hemicolectomy. The TLC was high with the significant neutrophilia. There was a mild derangement in the hepatic enzymes, and the PT was deranged with an INR of 2.1. Post-operatively, he was prescribed for an IV paracetamol and tramadol. And 20 minutes post-extubation, he complained of severe pain with an NRS of 9. So we thought we would start him on an IV fentanyl PCA prescription. They had given a loading dose of initial bolus of 25 mics because he was in severe pain. He was opioid naive, so there's no background infusion. We set a demand bolus of 10 mics with a lockout interval of 15 minutes and an hourly dose limit of 40 micrograms. A clinician bolus for breakthrough pain at 25 mics every 2 hours. And the patient was started on adjuncts. He was already planned for paracetamol, and we started an IV lignocaine infusion. So with an IV PCA, what do you monitor? Definitely the pain scores, vital signs, mainly the respiratory rate. If the respiratory rate is less than 8, you would be concerned. Sedation scores, in our institute, our nurses use the AVPU, but there are other institutes where the Ramsay agitation sedation score is used, and you look for opioid side effects, such as nausea, vomiting, and pruritus. So what if the patient has inadequate pain control with proper use of the PCA? Either the bolus dose is inadequate or the lockout interval may be too long. So in our patient, we could go up on the bolus dose from 10 mics to 25 mics because we are using fentanyl. The lockout interval is the lowest that, can go down from 15 to 10 minutes. If the patient is sedated, you reduce the dose of opioids by 10 to 20%. Since we are using the lowest dose of opioid, you could go up on the lockout interval from up to 10 minutes, from 15 minutes to 30 minutes. There are opioid side effects. Consider multimodal analgesia with adjuncts. And if the patient is not pressing the button despite pain, probably he is apprehensive that he might have an opioid overdose. Reassure the patient, and patient education could help. If the patient is overpressing the button, you would have to start off with a pain assessment to see whether the patient has inadequate pain relief with the PCA. And then you would review the pump for the demand delivered ratio. The ideal ratio is 1. If the ratio is more than 2, We have already discussed about inadequate pain control. The other causes are improper PCA use and insufficient PCA settings. Or you would need to talk to the patient, discuss with him why he is pressing the PCA button frequently, and try to re-educate him on the use of PCA. The second case is a 28-year-old preemie lady, first stage of labor, regular uterine contractions lasting about a minute, and request for epidural analgesia. Investigations were within normal limits, patient information given, risks explained, and an epidural was cited at L1, L2 space. Test dose given to rule out intravascular position of the catheter. So, as we have already said, 0.1% ropivacaine with 2 mics fentanyl is the most preferred PCA solution. Initial bolus of 10 to 20 ml, background infusion of 5 ml per hour, and the demand bolus 10 ml with lockout interval of 20 to 30 minutes. Maximum 4-hour dose of 100 mils. And monitoring, pain monitoring, the patient would tell you that the contractions are becoming shorter and she's having better pain relief. Whenever a clinician bolus is given, vital signs are monitored every 5 minutes for the first half an hour. Then the vital signs are monitored once every hour. Sensory block is checked for the level and whether it's equal on both sides. For the motor blockade, a straight leg raising test can be done. Some institutes do a modified Bromase scale, and opioid side effects are looked at. Fetal monitoring is very important. It has already been discussed. So if the patient is having a no block or a low block, you give a 10 to 20 ml bolus of the same solution and recheck after 20 minutes. If the block is not adequate, you resite the epidural at a different space. Unilateral block, you need to check the block yourself to ensure that it is unilateral. Look for the site of the pain. And a 10 ml of drug is given in the lateral position with the sore side down. You could also pull out the catheter by a centimeter and give a second top up in the lateral position. In spite of this, if it's not working, you would think about resiting the epidural catheter. Sacral sparing is usually seen in the second stage of labor due to perineal stretching. The epidural is sited at the lumbar level, so the drug might not be reaching the S2 to S4 level. So you need to give a bolus of ropivacaine. You can go up on the concentration to 0.15 to 0.2% and recheck after 20 minutes. If the block is inadequate, you think of resiting the epidural at the lower level. CSE for labor is one thing that could be considered. I was looking at literature and there was mention of dural puncture epidural for labor as well. Always consider other causes, a full bladder, progression of labor, orientation of the head. These are obstetric causes. Persistent occipito-posterior, and look for uterine scar tenderness if the patient has had a previous cesarean section. Thank you for your attention. The pre-filled bags for IV PCA and the epidural PCA from the pharmacy are used in certain centers to prevent drug errors, and I think they really make a difference because when the nursing staff are really busy, there is a likelihood of loading error occurring, and it could be dangerous to the patient.
So how much of lignocaine do you give? And when do you stop it? Like, do you just continue along with the IV opioid, or is it just an adjunct till the IV opioid effect sets in?
It is an adjunct till the IV opioid sets in, madam. We normally start with a 1.5 milligram per kg body weight initial bolus, and then we start an infusion up to a 1.5 milligram per kg per hour. So you give a 4 ml bolus of 2% lignocaine, IV lignocaine, and then start an infusion at 4 ml per hour. You continue evaluating the pain, and whenever the pain comes NRS score of 3, 4, you actually stop the lignocaine
Do you
infusion.
monitor blood levels at any time?
No, we don't do that.
Do you believe it's useful for abdominal surgery, IV lignocaine?
We actually use it in some of our patients.
And you're happy with the results?
Yes, ma'am.
Yeah. And it is only, obviously, you will not use it if there's an epidural ropivacaine.
No, we wouldn't use it.
You wouldn't combine local.
Yeah, no two modes of.
Okay, thank you.
Do you use IV lignocaine infusion intra-op as an adjunct?
Yeah.
Have you seen any delayed awakening with the patients who have received this IV lignocaine infusions?
I've seen, and we had initially tried doing a study, and the same doses, we used 1 mg per kg per hour. So when I saw a couple of cases, we abandoned that study.
Actually, most of the patients that I use are in long duration patients, and usually they go to the surgical ICU for post-op ventilation. So probably, yeah, I haven't observed it.
Thank you, sir.
Since there's a discussion about intravenous lignocaine, I think there is abundance literature to describe it as an alternative even to epidurals. So we have used it extensively. Delayed awakening occurs if you don't titrate the MAC properly. As per se, lignocaine intravenously doesn't produce that kind of sedation or delayed awakening. But once you do that, it's better to keep a MAC awake of about 0.6, 0.7 and keep it fixed at that. Then the awakening is quite good. But the quality of analgesia is good. It is excellent, I would say, and you can even give it for 48 hours.
Thank you, sir.
Thank you.
I now kindly call upon speakers Dr. LAKSHMI Kumar, Dr. Alexander Philip, Dr. Priyanka Kinney to join Dr. BASANTH Rayani on stage. I would like to welcome Dr. Manjunath Prabhu to present the memento to these speakers.